Hey guys, welcome back to Job Studies Med Fun. So here in part 2 of medicine, this time we're going to talk about restrictive lung disease. In the first part, we discussed about obstructive lung disease. So guys, in restrictive lung disease, what we have to remember is first the ratio. The FeV1 by the FVC ratio is this time going to be more than 0.8. Remember in obstructive lung disease, how much it was? Less than 0.7. Why this happens is that guys, even though FeV1 is less in restrictive lung disease, but the thing is the functional vital capacity is going to be forced vital capacity is going to be much more less than as respect to the FeV1, due to which overall it is going to increase. Okay, what I said is the FeV1 is going to reduce, but the forced vital capacity is going to reduce so much, due to which automatically the numerator is now going to increase, thereby the ratio is going to increase. So that is which is there in restrictive lung disease, again by the diagnosis of spirometry or pulmonary function test. Okay. What is there in restrictive lung disease is known as pneumoconiosis. What is pneumoconiosis, guys? It is nothing but an interstitial lung disease which is caused because of dust, due to which you will have interstitial fibrosis. What did I say? Pneumoconiosis is an interstitial lung disease which is caused due to dust, and the size of the particle will be around 1 to 5 microns, and thereby it is going to cause what? Interstitial fibrosis. Okay. Talking about the most common type of pneumoconiosis, guys, is going to be silicosis. Now in silicosis, guys, you need to remember what are the industries or what are the stones in which you will see. You have to remember, okay, this is a question related to silicosis. It is quartz crystals, glass industry, Kota stone, rock and sandblasting industry. How I remember this? Silicosis in a glass industry, where in Kota, where they produce what? Quartz crystals, and quartz crystals are nothing but rock and sands. What I said is silicosis occurs in a glass industry. What was the location? It was in Kota. And what they were producing? Quartz crystals. And crystals are nothing but rocks and sand. So this is a mnemonic which will help you to remember what are the sources to which silicosis occur. Now guys, why silicosis is very important? First of all, it is the most common type of pneumoconiosis. Along with the most common type of, when you do the x-rays, as I told you, all the radiological with respect to respiration, I will be covering it in radiology part 1 of respiratory. In the X-ray, guys, you need to know there will be a snowstorm appearance. Okay. First thing is snowstorm appearance, which is also seen in multiple other conditions like fat embolism and stuff like that. Remember, along with this, you will have bilateral lymphadenopathy. Now, this bilateral lymphadenopathy is going to be something like, if this is the lungs, right? So over here, they're going to be like circle like this around it, especially in the middle. That is why this is also known as eggshell calcification. That's why this is also known as eggshell calcification. All right. Remember that because of these conditions, because of silicosis, there is an increase of incidence of a disease, which is your pulmonary tuberculosis. This is a very repeatable question, so make sure you don't do a mistake in this. Okay. This is all about you need to know in silicosis. Next condition, guys. One more thing. Silicosis, remember, it occurs usually in the upper lobe. Now let's talk about asbestosis. Asbestosis, asbest, base is coming already there in the word. So remember, asbestosis occurs where, guys? In the base. What you have to remember in asbestosis, first of all, where it occurs. Okay, it occurs like in the wherever the mica industry is there, cement industry is there, shipping industry and insulation. So how I remember this as a mnemonic is mica insulted the ship and cement industry. There it is asbestosis. Okay, बहस हुआ, so asbestosis बहस किसके साथ हुआ था? Mica insulted ship and cement industry. That's how you remember for asbestosis. ठीक है? Otherwise, you can remember in however way you want. Okay. So now, what I want you guys to know is in asbestosis, what is the most common type of cancer? The most common type of cancer is adenocarcinoma. Now, whenever anyone thinks about asbestosis who has recently given the questions and all, he might always think about mesothelioma. Remember, guys, adenocarcinoma is going to be the most common type. While if they'll ask you which is the most specific, that time you have to mark mesothelioma. Guys, mesothelioma, it will present with bleeding, especially bleeding pleural effusion. Whenever you have bleeding pleural effusion, you have to always suspect 3 things. What? TB, cancer, or mesothelioma. Okay. As I said, whenever you have bloody pleural effusion, you'll always suspect TB, cancer, and mesothelioma. Okay. And remember, guys, asbestosis occurs in the base. Okay. Remember one thing. You will have coin shadows which are seen in the apex. The most common feature which is seen in asbestosis is pleuric calcification or plaques. Okay. pleural calcifications or plaques will be seen, and these are the most common signs which you find in asbestosis. Basically what happens is you will have some bodies which are known as ferruginous bodies or asbestosis, which will be found there in the images based when you see a lung x-ray. Along with this, what you have to remember is the most common type of cancer, which is an adenocarcinoma, specifically a bronchogenic cancer. It is the most common seen in asbestosis, but if they'll ask you which is the most specific, guys, it is going to be mesothelioma. Okay. Next in the pneumoconiosis is going to be anthracosis. Basically anthracosis, always you remember what you have to remember, it's going to be black lung. It is because of coal dust. Okay, whoever are working in the coal mines, because of coal workers, they have this. If they have in single thing, anthracosis in a prolonged time is going to lead into progressive massive fibrosis that also involved in the upper lobe. How do you see coal dust? Dust will be because of gravity, it goes up. So remember, okay, anthracosis, coal worker will be seen in which condition, guys? It is going to be in the upper lobe. Now remember, guys, there are 3 stages to this anthracosis. First is when it is of short duration and there are no symptoms. Basically, it is asymptomatic. If it is asymptomatic, guys, simply you will just call it as anthracosis. But after a while, okay, if you see prolonged duration, if there is any prolonged duration, provided after a prolonged duration, now this condition is known as simple coal worker pneumoconiosis, and this simple coal worker pneumoconiosis is going to have emphysema. And what type of emphysema, guys? It is going to be around a centriacinar emphysema. Okay, centriacinar emphysema. Remember, in smoking also it was centriacinar, while in case of alpha-1 antitrypsin deficiency it was pan-acinar. Correct? Again, even after this, if you don't treat it and this goes prolonged, then you will have now complicated coal worker pneumoconiosis. Complicated, first it was anthracosis, then it was simple coal worker, now it is complicated coal worker pneumoconiosis. Now in this condition, what you find, guys, is fibrosis, and whatever fibrosis, this is progressive massive fibrosis. This is progressive massive fibrosis. Okay, now one very important PYQ is, what if you get a patient, okay, who has rheumatoid arthritis and also has coal worker pneumoconiosis? What is the syndrome, guys? I'll give you a hint. It starts with C. Okay, and please mark the syndrome, because look, if I will tell you now, even though you will be so attentive, you will be able to remember it for a while. But right now, if you go and search, you'll check your notes and somehow you get the answer, that will be retained for longer. So please mention it in the comment below. If a patient comes with rheumatoid arthritis and coal worker pneumoconiosis, what is the diagnosis? What is the syndrome? Okay. Next, guys, we will be talking about the other hypersensitivity pneumonitis. One is bagiosis. Remember, bagiosis will be with respect to what things? It is going to be by cardboard and sugarcane. Byssinosis is because of cotton or textile industries and granuloma formation takes place over here. Byssinosis is also known as Monday chest tightness. Okay, and then will be berilliosis, that is because of aerosol or aerospace industries. Okay, what I want you guys to remember is all these conditions are coming under hypersensitivity pneumonitis. And next question which they ask is, in pathology actually, what is the type of hypersensitive reaction in hypersensitivity pneumonitis? Guys, it is a type 4 hypersensitivity pneumonitis. Okay. Next, guys, let's talk about infective lung disorders. Specifically, we'll talk about pneumonia. Now, guys, whenever you start about pneumonia, first you need to know what are the sequences, what happens in pneumonia. That is first congestion, then is red hepatization because of RBC which are present, then will be gray hepatization, and then will be resolution. You have to remember this order: congestion, red hepatization, gray hepatization, and resolution. Now, how do you remember this? After studying for very hard time with proper dedication, when you're going to get 200+ marks in your examination, I am going to congratulate you for really great results. So remember this mnemonic: congratulate for really great results. So remember, congratulate से congestion आ जाएगा, then really which will be for red hepatization, great will come for gray hepatization, and result RES is resolution. ठीक है? It's all about, you know, integrating and making sure that you're having fun while studies, and that is the secret. Now I'm telling you, if you study this in the last 1-2 weeks, you will be very stressful. Right now you have good amount of time for your examination. Study it slowly, enjoy it, understand why are they asking this, and move on, and you'll tend to remember it for longer time. Okay, now talking about, we have already talked about the stages: congestion, red hepatization, gray hepatization, and resolution. Now let's talk about what are the types of pneumonia. Guys, there are 2 types of pneumonia. One is going to be a typical pneumonia, another one is atypical pneumonia. Now, why this typical pneumonia? Because it is involved within the air spaces. You can see it is involved within the air spaces. While if you see atypical pneumonia is something which is involving the interstitial space, it's not involving in the air spaces. Okay, so you'll have in the normal typical pneumonia, let's discuss about typical pneumonia, and side by side we'll talk about atypical pneumonia. So you'll have bacteria. This bacteria will start putting excretive. Excretive basically means inflammatory markers. And then they'll be having, you'll hear crepitations, you'll have crackles. Usually in atypical or interstitial pneumonia, the signs, which why in one way you call it as walking pneumonia at times, especially with respect to mycoplasma pneumonia, is because the patient comes with very vague symptoms, like I just have a mild cough, I just have a mild fever. But when you do an X-ray, there'll be bilateral infiltrates. You will be like, how is this guy so well? He should be literally on the bed. So that is why you're thinking it is like, ulta pulta wala thing. So that is why this is known as walking pneumonia. That is your atypical pneumonia. But on the other hand, a proper pneumonia which we think about is they are going to have whatever fever, guys, they are going to have high grade of fever. They are going to have high grade of fever. They are going to have productive cough. They are going to have productive cough. And along with that, they will also have difficulty in breathing. High grade fever, productive cough, dyspnea, and also they will have pleuritis. Okay, high grade fever, productive cough, dyspnea, and pleuritis. Atypical is ulta. So what will be in atypical, guys? You will have low grade fever. Low grade fever. You will have dry cough and mild. Malaise means body weakness. Mild body weakness will be there. Okay. So now let's talk about them one by one. Let's talk about typical pneumonia. In typical pneumonia, guys, the most common type, which is your community acquired, CAP stands for community acquired pneumonia. That is going to be pneumococcus. Pneumococcus is also known as Streptococcus pneumoniae, right? It is an alpha hemolytic Streptococcus. Next, let's talk about nosocomial pneumonia. Guys, what is the meaning of nosocomial pneumonia? Nosocomial pneumonia means which is pneumonia which is acquired from home or out. Pneumonia which is acquired in the hospital within, this is important, within 48 hours. Okay, within 48 hours, that is the main thing you need to know. So hospital acquired pneumonia, that is known as nosocomial. Again, this is because of which organism it will be there. Mostly it will be Staphylococcus aureus. Okay, then VAP stands for ventilator associated pneumonia. Ventilator associated pneumonia is going to be, guys, Pseudomonas. It is going to be Pseudomonas. Staphylococcus aureus will be basically a secondary pneumonia, because if already a patient got Streptococcus pneumonia, again if someone develops a pneumonia, that will be a secondary pneumonia, that is called by Staphylococcus aureus. They will eventually develop pneumatoceles. Okay, it's like air cavities within the lungs, you can see, and then later this can rupture and leading to spontaneous pneumothorax. Okay. If you have a person who is having a history of alcohol consumption and who has history of aspiration, and with this you have another feature of red currant jelly sputum. Red currant jelly sputum. Your answer is going to be Klebsiella pneumonia. Okay, but if they ask you in this surgery question, red currant jelly stool, that is, guys, seen in which condition, guys? It is seen in intussusception. That is seen in intussusception. Okay. These are all which will be seen in your typical pneumonia. Remember which are the cause. Again, I'll tell you. Pneumococcus, nosocomial pneumonia, ventilator acquired pneumonia, secondary pneumonia, Klebsiella pneumonia. These all come under typical pneumonia, which will have high grade of fever, productive cough, difficulty of breathing, and pleuritis. Now let's go to atypical pneumonia. Atypical basically means symptoms are very vague. Low grade fever, dry cough will be the mild body weakness. But when you see on the X-ray, there are bilateral infiltrates, it looks very worse. The first thing which you always have to remember is mycoplasma. Now, mycoplasma pneumonia, as I said, you also known as walking pneumonia, is usually seen in crowded places such as jails. Okay, or where when an army recruits are there together without any sanitation or something like this. Okay, chlamydia pneumonia is usually seen as bird pickers. Whenever they and mostly it is related to the bird feces will be there. All right, if they ask you what is the drug of choice for chlamydia pneumonia, you have to give tetracycline, which is the doxycycline. Okay, Legionella pneumonia. Now, Legionella pneumonia will be associated with the triad, guys. The triad is if a patient comes with you with pneumonia, altered syncytium, and diarrhea. Pneumonia, altered syncytium, and diarrhea, always suspect Legionella pneumonia. I'll talk about this detail, why is there altered syncytium, in the next slide. Okay, Virus, again another cause of atypical pneumonia. Example will be measles and RSV. Remember guys, we talked about RSV in case of pediatric cases also. What was it causing? It was causing acute bronchiolitis. Now acute bronchiolitis, which was there, okay, what drug were given? We were giving guys ribavirin. What drug we were giving? Ribavirin we were giving. Amantadine is also given in case of influenza type conditions, right? Next condition guys, when you will have an immunocompromised HIV patient whose CD4 count was around 200 and then you discovered that patient had pneumonia. When you saw the pneumonia, you thought he has a productive cough and something like this, but when you did an X-ray, there was like the X-ray was normal. What is your cause of pneumonia? That is going to be your pneumocystic cerevocai. What is going to be? It is going to be pneumocystic cerevocai. They'll ask you what stain is there. In pneumocystic cerevocai, you'll have methamine silver stain. Methamine silver stain. They'll ask you what is the drug of choice in case of pneumocystic cerevocai. Again, we have to integrate all the subjects. So the drug of choice for pneumocystic cerevocai is co-trimoxazole. How do you divide this? Co means combine. Tri is trimethoprim and moxazole is sulfamethoxazole. This will have sequential inhibition. What do you mean by sequential? Inhibition is they basically inhibit from the folic acid synthesis to dihydrofolate reductase. There is another, like one is folic acid synthesis. Remember, I'll talk about this. Remember, sulfamethoxazole inhibits folic acid synthase. Okay, whereas trimethoprim inhibits dihydrofolate reductase. Okay, that is trimethoprim it inhibits, and the ratio is very important in this guys. In co-trimoxazole, remember the ratio of trimethoprim to sulfamethoxazole is 1:5. How do you remember this? Guys, look, sulfamethoxazole S na, it looks like a 5. Sulfamethoxazole S looks like a 5. So always remember the ratio of trimethoprim is 1:5. Okay. Trimethoprim, remember guys, it is bacteriostatic. It does not kill the bacteria but stops the growth. Whereas both of them actually, I'll just confirm with this. Okay, both are bacteriostatic in nature. But you have to remember trimethoprim is bacteriostatic in nature. Okay, ratio is going to be 1:5, and they'll have sequential inhibition. Now guys, usually in atypical pneumonia, we are going to give drug of choice as macrolides. Now why macrolides guys? Because see, mycoplasma, it has a thing. It does not have absent of cell wall. Now if it does not have cell wall, there is no role of penicillin. Because guys, penicillins, amoxicillin, these guys, they all act on the cell wall. For that, then what you have to give, remember M for mycoplasma, M for macrolides. That's how you can remember it. Okay, so now example of and the strongest and longest acting macrolide is going to be azithromycin. So azithromycin is nothing but it will be blocking the protein synthesis, and it's a long acting macrolide. So what are the conditions in which you can give azithromycin? Remember, azithromycin or macrolide drugs by given by CLAW. Okay, CLAW. Chlamydia pneumonia, Legionella, atypical pneumonia, and whooping cough. What did I say? Chlamydia pneumonia, which will be there in atypical pneumonia. Also C stands for chancroid, Legionella, atypical pneumonia, and whooping cough. These are the use of macrolides. You can remember this, okay? In pharma also we'll discuss this, but right now also you can remember. Guys, amantadine is an antiviral which is also used in Parkinson's. Another point we have to remember, okay? Now guys, if you talk about the treatment in case of typical pneumonia, right now azithromycin and all we discussed with respect to what, and like ribavirin we discussed about atypical pneumonia. Now let us talk about typical pneumonia. In typical pneumonia, now there is no issue like there is no cell wall, there is cell wall. So that's why what you're going to give, we are going to give penicillin. The only side effect of penicillin is anaphylaxis, but rest it is a very good drug. So it is a cell wall synthesis inhibitor. Example is going to be amoxicillin, amoxiclav, which is also known as augmentin. Probenecide is a drug which is used in case of gout, in uric acid ko secretion वगैरह. But probenecide guys has found that increase the efficacy of penicillin. Okay. Now if you talk some more detail about penicillin, again let's add pharma. There is something which is known as procaine penicillin. Procaine penicillin is used in case of syphilis. In which type of syphilis? It is used in neurosyphilis. The longest acting penicillin which is there we have, that is known as benzathine penicillin. That acts for how much days guys? 21 days. Now these are all related to injections. Now there is something which are oral penicillins. And how do you remember oral penicillins? You have to remember, whenever you drink vodka, you drink it orally. So remember vodka. Oral effective penicillins, the mnemonic is going to be vodka. V stands for penicillin V. O stands for oxacillin. D stands for dicloxacillin. K and C have a same rhyming word, so now in this you have to do thoda jugaad, okay? And that is going to be cloxacillin. Cloxacillin, remember K, and then ampicillin, amoxicillin will be A. So these are all oral penicillins, okay? It has been asked in previous year questions, so make sure you know this as well. Next, guys, as I was talking to you, I will talk about a detailed explanation with respect to Legionella pneumonia. Legionella pneumonia, as I told you, it is seen as an atypical pneumonia. Now, we talked about the triad, guys. A triad will be a patient who comes with a history of pneumonia, who also has diarrhea, and now who also has altered sensorium. Okay, pneumonia, we understand infection, diarrhea, we understand infection, but why altered sensorium? Guys, this Legionella species, right, especially Legionella pneumonia, causes and gives us an effect of SIADH, syndrome of inappropriate antidiuretic hormone. As you know, ADH, what it does is it increases the water retention. Now you guys know in our fluid there is a balanced electrolyte level. If in a balanced electrolyte level I will add so much water, if I add so much water, guys, the amount of electrolyte which was older previously there, it is going to be that much only, there will be no increase. But if I just imagine, if in this water bottle there is this much water and there will be a little bit of like anything which we want to eat, like some solid particles are there. If we add the water, the solid particle content will be basically less. So that is why there is a condition in Legionella pneumonia which is known as dilutional hyponatremia. Dilutional hyponatremia means what? We are taking all the water in, but due to which the sodium level there is no change. It is always going down, but with respect to the content of water. So that is why you have something which is dilutional hyponatremia. If you see this, it is actually a euvolemic hyponatremia, which means it is completely normal, but with respect to its surrounding, it is less. Now, because of its surrounding, it is less, guys. Whenever the sodium level is less than 125 milliequivalent, you will have patients present with altered sensorium or seizures. So remember, guys, anytime pneumonia, seizures, dyselectrolemia, diarrhea is there, remember there is suspect about Legionella pneumonia. Guys, for SIADH in pharma, you have to remember the drug of choice are always Vaptans. Okay, for a syndrome of inappropriate antidiuretic hormone, the drug of choice is going to be all Vaptans. Okay. Now, guys, whenever you talk about pneumonia, there is a score which is known as Curb 65 score, which tells us whether we have to hospitalize this patient, whether it is an OPD based, whether it is an inpatient, or whether it is an ICU based. How do you check this? Is by Curb 65 itself. It is a mnemonic where C stands for confusion, U stands for BUN, R stands for respiratory rate, which is more than 30, and B, which is blood pressure, which is less than 90, when the blood pressure is going to be 90/60, and age is 65. Okay? More than 65. Each will give 1 point. So this is Curb 65 score. In Curb 65 score, guys, if the score is 0 to 1, it is going to be based on outpatient basis. If it is 2, then you will be inpatient, but not as, like IV in ICU, it is going to be in general ward. But if it is more than 2, you have to take it as an ICU basis. This is a criteria for hospitalization in pneumonia. Now, guys, as we discussed, we'll just bring more elaboration into it. Community acquired pneumonia, the cause will be pneumococcus. Now, guys, streptococcus pneumococcus is also a cause for acute bacterial meningitis. Now, what is the drug of choice, guys? Remember we talked about earlier the DNA gyrase inhibitor, that is fluoroquinolones. In fluoroquinolones, we talked about oh my god lungs, where G we are not using because of hepatotoxicity, but ofloxacin, moxi, and levo can be used for respiratory infections. Along with that, a macrolide, which is azithromycin, is used. Nosmocomial, guys, it is hospital acquired because of Staphylococcus aureus. Important thing is, remember, guys, 48 hours, very important. Within 48 hours, then only you will be acquiring it. What is the infection? Which bacteria which is causing the pneumonia and cystic fibrosis, guys? That is going to be Pseudomonas. You guys might have noticed something. Pseudomonas comes in so many conditions, right? See, Pseudomonas here also. Alcoholic patient also Pseudomonas. Because why it will be there? It is going to cause a it is because of an anaerobic bacteria. And what will it cause, guys? It is going to cause abscess. What is it going to cause? It is going to cause abscess. If you have now an alcoholic patient with red currant jelly sputum, now the condition is not going to be Pseudomonas, it is going to be Klebsiella. Okay, guys, Pseudomonas ka color jo hota hai na, if you will see the discharge, it is going to be blue green. Another, in microbiology, what question they ask is, why is the discharge blue green in Pseudomonas? Because of a chemical which is known as pyoverdin. Okay, they have asked this because of channel is pyoverdin. Micro also humne add kar diya. Okay, so we're done with this. Okay, Next guys, let us talk about a history. There is an AIDS patient. Already we talked about it, but let's go a bit more detail. A AIDS patient who is a history of a truck driver. So he had the complaints which he came out, he had fever and difficulty of breathing. When you did the X-ray was normal. When you check the CD4 count, the CD4 count was low, around 200. On the stain, what you did was you did a glomerulomethamine stain, in which you found out the diagnosis as pneumocystic cerevocai. Pneumocystic cerevocai, guys, what is the treatment, guys? It is cotrimoxazole. Now, if you know he's an HIV patient, if you know that you want to prevent such infection like pneumocystic cerevocai, you can also use the same drug, which is cotrimoxazole, as a prophylaxis. Remember, guys, what I told you, it is co means combination, tri is trimethoprim, sulfamethoxazole. The ratio, guys, it will be 1:5. Remember, sulfamethoxazole, S and 5 looks the same. Correct? Again, another question, guys. You have an alcoholic guy. He went to Holi. In Holi, guys, what happened was he drank too much bhang. Now, because of drinking too much bhang, he was in super nasha. He slept for 2 days. Now, whatever he ate, some things he tried to vomit, but he was not able to vomit, and some of this food particle went inside his lungs. Now, because it went inside his lungs, he developed when he woke up, he developed fever, chills, difficulty in breathing, everything. You did an X-ray. On X-ray, you said air fluid level was seen. Guys, air fluid level, whenever you see in the X-ray, this is a suspicion of lung abscess. And lung abscess is mostly caused by an anaerobic organism. That is going to be your Pseudomonas. Okay? Complaints will be of foul smelling, productive cough because there is an infection. You'll have air fluid level also will be present. Treatment is going to be, since it is an anaerobic organism, you are going to give metronidazole. Anaerobic organism, you're going to give metronidazole. Now, the side effect of metronidazole, guys, is metallic taste. You will not feel like eating food or something like this. That is why always give metronidazole after meal, so that you will eat the meal and then you can take it. Okay? Remember, guys, you never give the patient alcohol, and you remind the patient don't take alcohol if you're taking metronidazole. Why, guys? There is a reaction. What is the reaction, guys? It is disulfiram reaction. Now, what is disulfiram reaction, guys? I hope you guys are able to pause the video and remind yourself what was the reaction, because next I'm going to talk about that only. Okay? Now, guys, disulfiram reaction, before knowing about disulfiram reaction, you need to know what is the pathway of metabolism of alcohol. So whenever you consume alcohol, guys, what happens? Alcohol or ethanol, okay? This gets broken down into acetaldehyde with the help of enzyme alcohol dehydrogenase. This acetaldehyde further gets broken down into acetic acid because of aldehyde dehydrogenase. So पहले क्या याद करना है? First, which enzyme was alcohol dehydrogenase, then was aldehyde dehydrogenase. Now, what happens is drugs which are causing disulfiram, example will be metronidazole. I'll give you a mnemonic, that is CGMP. These drugs, what they do is they inhibit this aldehyde dehydrogenase. Because they're inhibiting this enzyme aldehyde dehydrogenase, you are not able to convert acetaldehyde into acetic acid, due to which you will have accumulation of acetaldehyde. Because there is accumulation of acetaldehyde, this will start giving you symptoms like nausea, anxiety, and abdominal pain. Now, this is so dangerous. Now, what happens is usually if you will see a drunk husband will be there, okay? The wife is so tired, exhausted about him. So then what she must have heard from a friend or a family doctor that this disulfiram reaction will stop your husband from drinking alcohol for sure. Because obviously if ever you drink alcohol, these symptoms, nausea, vomiting, anxiety, abdominal pain, suicidal tendency, so much is there. So obviously you will stop to drink. But if the patient is not aware about it, and you gave it accidentally in something he was drinking, and you gave it like this, and he went to drive, and these all symptoms occur after drinking alcohol. He might be driving a car, he might be, in some situation where all of a sudden this pain hits, he might also have an accident, and it can also cause death. So that is why always it is ideal, whenever you give this any disulfiram like drugs, you should mention and make the patient aware that please do not consume alcohol, otherwise such symptoms can also cause death, right? If you want to remember, guys, what are the drugs which are causing disulfiram reaction, you have to remember this with the mnemonic of CGMP, where C, guys, stands for cephalosporin, cell wall synthesis inhibitor, griseofulvin for G, which is an antifungal, metronidazole, guys, and procarbazepine, which is an anti-cancer drug. These are the disulfiram reaction which are basically using aversion therapy in case of alcohol. Okay, guys. Now, just some general topics. Remember that most of our respiratory tract is lined by what epithelium, guys? Pseudostratified ciliated columnar epithelium. What is the role of cilia, guys? Cilia helps in motility. Cilia helps if there is accumulation of mucus. This mucus is going to be pushed out with the help of the cilia. Now, if the cilia is less, there will be problems, there will be infection, and there will be much more like, the respiratory tract will basically get messed up. So what are the conditions, guys, where the cilia is less? Number one which we talked about was COPD, smoking. We mentioned that multiple times. Other conditions will be Kartergener syndrome and cystic fibrosis. Guys, in Kartergener syndrome, mostly they will ask you the triad. The triad of Kartergener syndrome is sinusitis, bronchiectasis, and situs inversus. Situs inversus is whenever your heart is usually in the left side, it turns into the other side. This is also known as dextrocardia. Dextro means right side. Okay? Other condition which you have to remember, guys, is cystic fibrosis. In cystic fibrosis, you'll have the CFTR gene. And I told you in cystic fibrosis, what pneumonia you see? You see because of Pseudomonas aeruginosa. Remember, guys, Pseudomonas aeruginosa is also associated with ventricular associated pneumonia. I talked to you about this in case of typical pneumonia. And the color which is there, the pigment which is the blue-green, is because of pyoverdin. Actually, it is not pyocyanin, sorry, it is pyoverdin. Okay. A last topic which I want to discuss with you is the type of surfactants, which type of pneumocytes which produce surfactants. Remember, guys, alveoli has two types of pneumocytes, type 1 and type 2. The type 2 is the one which is producing surfactants. Now, what is the role of surfactants? Guys, basically what the surfactants do is it reduces the surface tension in the alveoli. Because usually what happens is in expiration, the air is, we are removing the air, the pressure increases. So there is a chance of collapse of the alveoli. This collapse is prevented by the surfactants. Now, surfactant production is usually done after 32 weeks of gestation. That's why in case of prematurity, very commonly you will have the surfactant deficiency, thereby which you will have respiratory distress syndrome, which we already discussed in pediatrics. You'll have hyaline membrane disease, white out lung. What is the management, guys? The management is simple. You have to give first corticosteroids, which will be dexa or beta-methasone, beta-methyl 2. So you'll have 2 doses of 12 mg 24 hours apart. Dexamethasone, guys, it will be 6 mg. This time dexa will be 4 doses, 6 mg 12 hours apart. Okay. What is there in surfactants, guys? It is DPPC, dipalmityl phosphatidylcholine. Okay? If you will talk about the causes which will be there, the causes will be prematurity. Prematurity means, as we talked about, neural respiratory distress, you will have whiteout lungs, hyaline membrane disease. Eventually, you have to give oxygen therapy, steroids, and mainly you have to give intratracheal surfactant. So, guys, this is all for the part 2 of medicine. See you guys in part 3 of medicine. Take care, study well.